Imagine an outbreak sweeps through a district of 1 million people. You need a health architecture built from scratch, and you need it fast. You need a social physician. The blueprint for this scenario dates back to 1946 with the Boer Committee. Remember, Boer equals before independence. This committee laid down two foundations: the 3 million plan for long-term infrastructure and the original concept of the Primary Health Center, or PHC. Today, we are going to map out this entire Indian healthcare system on screen. We'll build a single, comprehensive mind map to decode exam questions and understand how real-world public health logistics actually work. Mastering these committees and structures provides the literal blueprint for how 1 billion people survive health crises. Let's start at the ground level. A pregnant woman in a remote village of 1,000 people needs basic health guidance. Who is her very first point of contact? Look at this table detailing population norms. Her first contacts are the boots on the ground, the ASHA worker, staffed at 1 per 1,000 population, and the Anganwadi worker, staffed at 1 per 4 to 800. This strategy of utilizing local community members traces directly back to the Shrivastava Committee in 1975. They recommended creating these bands of paraprofessional health workers from within the village itself. Moving one level up the hierarchy, we hit the subcenter. This facility caters to a population of 3,000 in hilly or tribal areas and 5,000 in the plains. These subcenters are manned by multi-purpose workers, or MPWs. We have the Kartar Singh Committee of 1973 to thank for implementing that specific multi-role staffing model. Not all subcenters are identical. As shown at the bottom of this page, they are divided into Type A, which handles basic recommended services, and Type B, which is specifically equipped with facilities for conducting deliveries. These first two levels, the village workers and the subcenters, act as a filtration system. They absorb minor health issues locally, which reduces the patient load on larger hospitals. If a case is too complex for the subcenter, it moves up to the Primary Health Center, or PHC, which covers 20,000 people in hilly regions and 30,000 in the plains. This is a critical threshold. The PHC is officially defined as the first point of contact between the village community and an actual, fully qualified medical officer. To handle the medical load, the physical footprint expands. This table breaks down the requirements for a PHC, mandating a team of 13 to 21 staff members and a provision of 4 to 6 beds for indoor patients. The operational philosophy driving the PHC comes from the 1978 Alma Ata Declaration. It established the hallmarks of primary healthcare based on 4 A's: affordability, acceptability, accessibility, and availability. But what if a patient at a PHC needs a specialized surgeon or a pediatrician? The medical officer escalates them to the next level, the community health center. Covering a population of 80,000 to 120,000, the CHC is classified as the first referral unit in the system. The scale jumps significantly here, requiring a 30-bed hospital and a specialized staff of 46 to 52 personnel. By standardizing these population ratios, the system creates a predictable flow for patients, ensuring that specialized surgeons at the CHC level are reserved for cases that have already been vetted by the village and subcenter levels. Building this massive physical map is one thing, but how does the government actually fund, evaluate, and track it all? That administrative planning is now managed by Niti Aayog. To evaluate programs, planners rely on 2 economic tools. While cost-benefit analysis measures outcomes in monetary terms, cost-effectiveness analysis measures benefits in natural units, like quality-adjusted life years, or QALYs, making it the most widely used metric in health management. For logistics, planners use network analysis tools like PERT and the critical path method, or CPM. CPM calculates the absolute longest sequence of tasks in a network to identify where potential delays would impact the final objective. These quantitative techniques ensure clinics are staffed efficiently and that limited funding is directed toward interventions that yield the highest impact on public health. Let's pull back and look at the complete architecture. From the foundational ideas of the Boer Committee, through the village ASHA workers, up the referral ladder to the CHCs, all the way to Niti Aayog. Let's do a rapid-fire review. Who recommended the multi-purpose workers? The Kartar Singh Committee. And what facility serves as the first referral level? The Community Health Center. Every staffing norm and bed count is a specific calculation designed to distribute survival to over 1 billion people. Take a screenshot of the completed mind map right now. Keep it saved on your phone and use it as your ultimate high-yield exam cheat sheet.